Assalamu alaikum. I'm Dr. Habibur Rahman. I'm basically cardiologist, interventional cardiologist. I do intervention in coronaries and occasionally peripheral intervention. So it's my privilege and honor to present my few words in this August gathering. Mr. Chairperson and panelists and audience. So my topic, as mentioned, the Femoropopliteal occlusive disease. So first of all, I would like to mention which region is called femoropopliteal zone. As we know, the femoral artery starts from the common femoral artery just after the bifurcation of the profunda femoris. This is one of the longest artery of the body, and popliteal portion just is the continuation of the femoral artery, just crossing the adductor canal. So as a whole, the superficial femoral artery and popliteal artery lesions becomes very complicated and poses great problem for the interventionist to intervene when needed. So if we classify the lesion as per the TUST classification, it is type A and type B. These are amenable to intervention by endovascular intervention. And type C, it depends upon the operator. Operator can do endovascular procedure as well as surgery depending upon the risk, benefit and probable outcome of the case. And type D, of course, they're typically indicated for surgery. Nowadays, with the advent of the devices and other facilities, techniques, improvement of techniques, so we can touch these sorts of lesion by endovascular approach. So when indicated for intervention in this zone, the life-limiting moderate to severe claudication in patients who have failed medical management, that is by either silostazole or exercise program or by any other drugs. And critical limb ischemia, which we know by rest pain, non-healing ulcer or gangrene, and pre or post bypass surgery to increase the inflow or outflow. Salvage of failing bypass graft with significant flow limiting stenosis at the anastomosis or outflow vessels. So the unique challenges of intervention here in femoropopliteal segment remains the most hostile arterial bed in the body, as already mentioned. Variation in shear stress at this location combined with extreme degree of flexion, elongation and tortuosity lead to high degree of calcific arterial sclerosis. These factors make placement of most bare metal stents extraordinarily challenging, which has been seen in multiple meta-analyses of trials involving bare metals at this location. So for endovascular techniques, we have to consider some points regarding arterial access, sometimes contralateral femoral access, sometimes antegrade access when the lesion is at the lower zone, not involving the upper femoral or common femoral or ilia. It depends upon the management strategy, depends upon the whether it is acute occlusion or chronic limb ischemia, due to chronic occlusion. And we have to consider the crossing of the lesion. In most of the cases, it remains CTO. So dealing with CTO involves devices as well as techniques as well as other modalities. So we have, whether we have to do angioplasty alone, that is plain balloon angioplasty, or stenting, whether we have to do debulking by atherectomy and leaving nothing behind and putting dark coating balloon. So we need to consider all these points before going for endovascular procedure. So let us share a few cases. A case of superficial femoral artery occlusive disease. Here is a known case of coronary artery disease who has been recently treated with multivessel PCI and was referred to us for left femoral artery disease evaluation. He was a smoker, diabetic, and having history of non-healing ulcer in his great toe. His peripheral angiographic runoff revealed flash occlusion of the left superficial femoral artery and reconstitution at the level of the popliteal artery. Collaterals from the profunda femoris connecting to the branches of popliteal artery, but these are not adequate. Distal basis below the knee seems to be patent as faintly visible. So this is the case, flash occlusion of the SFA, and we have started the intervention by placing a microcatheter, that is support catheter, along with coronary wire. As I mentioned, I am a coronary person, so I prefer in most of the cases in peripheral as well, coronary devices when possible. So lesion crossed and it was CTO, and distal entry ensured by checking the support catheter through the support catheter. And started self-expanding nitinol stent implantation started from the P1 segment of the popliteal artery. As you know, popliteal artery is being divided into P1, P2, and P3. So upper part is P1, and connecting it completed the whole SFA with good distal runoff. So another case, a 59-year-old gentleman presented with history of incremental right leg pain for a couple of weeks. He was a smoker, hypertensive, and diabetic. He had severe coronary triple vessel disease and planned for CABG. And cardiac surgeon decided to do CABG, but after solving the issue with his leg, so he was referred to us and found the total occlusion at the mid-level of the SFA. And this case, I started antegrately as there is adequate length is present in proximal SFA. So easily crossed the wire with Terimo wire guided by 5 French RCA catheter and ensured the distal entry. So balloon dilatation done and stented with 6/100 BMS stent, and after implanting the first stent, found lesion above this and another BMS put and with good flow. So it was definitely an easier case. So case scenario 3, a 52-year-old male was referred to us by his physician due to blackish discoloration of discoloration and severe pain over the last few weeks involving the first 3 digits. Initial clinical inspection revealed clear evidence of arterial insufficiency involving digits 1 through the left foot, and femoral pulse were present but bilaterally, but however popliteal pulse on the affected foot was diminished. And duplex ultrasound recording showed marked diminished amplitude and blunting of the waveforms at the lower level, at the tibioperoneal trunk and downwards. So given the patient's creatinine, it was 2.13, so CKD, it was decided to proceed diagnostic angiography without doing CT angiogram. Angiography revealed severe diffuse disease involving the distal third of the SFA, becoming a total occlusion at the P1 segment of the popliteal artery, and reconstitution via genicular collaterals at the level of this distal tibioperoneal trunk was evident. The anterior tibialis and peroneal arteries were unaffected, but the posterior tibialis was totally occluded at the lower part. So this was the case, and started intervention with coronary wire, CT wire of course, with the guidance of microcatheter. So crossed easily and balloon dilatation of that zone with good results. So all the cases are not alike. In that case, a 65-year-old lady had bilateral intermittent claudication and underwent plain balloon angioplasty 2 years back in another hospital. For last couple of months, her symptoms recurred and evaluated by duplex ultrasonography. Angiographic runoff revealed this. That is, spontaneous dissection like phenomena in the popliteal zone. So should we intervene this case again or send to the surgeon? It's a matter of debate. So I deferred, I sent the case to surgeon. Of course, here if we open this and can put DCB, it will suffice, I think so. So, Mr. Chairman and panelists, in conclusion, the femoropopliteal artery is the most common site of disease in patients with peripheral arterial disease and presents some of the greatest challenges for interventional operators. Many patients can be managed with medical treatment combined with supervised exercise at home alone. However, a significant proportion of, especially those suffering from severe intermittent claudication or critical limb ischemia, will require some form of endovascular or surgical revascularization procedures. During the past few years, an endovascular first approach has gained support from all vascular specialties. Today, even complex lesions can be treated successfully with an endovascular approach. Unfortunately, the unique biomechanical properties of this vascular segment have limited long-term patency rates and clinical value of the endovascular options. So thank you for patient hearing.